Okay, let's unpack this. We're diving headfirst into elbow trauma today, specifically looking at dislocations and, the even trickier fracture dislocations.
Yeah, they can get pretty complex.
Exactly. And if you're an orthopedic resident, maybe getting ready for those postgraduate exams, this deep dive is really for you. We're aiming to sort of distill the key information, make it efficient.
Hmm.
Everything we're discussing today is based on the fantastic Ortho Made Simple notes, which you can find on the website mokyingren.sg.
Those are great notes.
They really are. And full credit to the creator, Dr. Mok Ying Ren. He's a sports surgeon over at National University Hospital in Singapore, finished his FRCS back in 2022. So his insights are pretty current.
Definitely.
Right, let's jump in. When you look at the elbow, what actually keeps it stable? What are the main components?
Well, it's interesting. It's a mix of things. You've got the bony anatomy, of course,
Yeah.
the shape of the ulnohumeral joint, how well it fits together. It gives inherent stability, especially when the arm's straight in extension. But, probably the real heavy lifting comes from the ligaments, specifically the medial collateral ligament, the MCL, and the lateral collateral ligament complex, particularly the LUCL, the lateral ulnar collateral ligament. They're the primary soft tissue restraints.
So when things go wrong, like a dislocation, it's often those ligaments failing.
That's usually the root cause, yes. The soft tissue stabilizers giving way.
And it's not just a random tearing, is it? I understand there's often a sequence to it.
Precisely. That's the idea behind progressive instability, which the Circle of Horry describes really well. Think of it as stages. The injury force usually starts posterolaterally.
Okay.
So you get failure of the LUCL first, maybe the joint capsule tears a bit too, anteriorly and posteriorly. That's like stage 1, posterolateral rotatory instability, or PLRI.
Right, PLRI.
If the force continues, the elbow displaces further. It might sort of perch where the coronoid bone is just balancing on the trochlea of the humerus. That's stage 2.
Perching, okay.
And then, if the force keeps going, you get a complete dislocation. The joint surfaces are totally separated. That's stage 3. And by this point, it means the medial ligaments, the MCL, have also failed, along with the lateral side and capsule. It progresses around that circle, lateral, capsule, then medial.
Got it. Lateral capsule, medial for the full dislocation. Okay, let's focus on simple dislocations first. So no fractures yet. What typically causes one of those?
The classic story, and O'Driscoll described this mechanism well, is a fall onto an outstretched hand. But the key is the forearm position. It's usually supinated or externally rotated.
Oh, yeah.
And that combines with a valgus force, so the elbow is pushed inwards, and axial compression, like the force going up the arm. Often the elbow is a bit flexed too. That combination just levers the forearm bones right off the humerus.
In which direction do they usually go?
Posterolateral is by far the most common, over 90%. That's your typical simple elbow dislocation.
Are there other directions we should worry about?
Yes, the one that really flags a potential problem is posteromedial. It's rare, like less than 1%, but if you see that pattern, you should immediately suspect much more significant soft tissue injury, especially on the medial side. It's a red flag.
Okay, good to know. So posterolateral is common, LUCL goes first. Where exactly does the LUCL tend to fail? Is it mid-substance or at an attachment?
Most often it fails proximally. It tears right off its origin on the humerus, on the lateral epicondyle area.
Right off the bone.
Yeah. There was a study by McKee, looked at about 62 patients, I think. They found that humeral avulsion, sometimes with a tiny bone fleck, happened in over 60% of cases. Mid-substance tears or pulling off the ulna were less common. So if you're thinking surgery, you're often thinking about fixing it back to the humerus.
Interesting. So the humeral side is the weak point there. With that kind of force, posterolaterally, are nerves at risk during the dislocation?
Oh, absolutely. You always have to check nerves. The median nerve is the one most commonly affected, and specifically its branch, the anterior interosseous nerve, the AIN. Yes, especially with that posterolateral displacement pattern, it's actually quite similar to the nerve injury risk you see in displaced supracondylar fractures in kids, which often displace posterolaterally too. So checking AI function, like asking the patient to make an OK sign with thumb and index finger, is critical after you reduce the dislocation.
Okay, so simple dislocations.
Yeah.
Usually posterolateral, LUCL, often tears off the humerus, check the AIN, and a complete simple one is stage 3 Horry. Right. So the elbow's out. How do you get it back in? What's the reduction technique?
The standard is often the two-person technique. Patients lying down, supine, you flex the arm a bit, One person pulls steady traction on the forearm lengthways to kind of unhook the bones.
Gentle traction.
Gentle but firm, yeah. While the first person is pulling, the second person uses their thumbs directly on the olecranon, the pointy part of the elbow, and pushes it forward and slightly downward, guiding it back into place under the humerus. It should be controlled, not a forceful jerk.
Okay, makes sense. So you get it reduced. Then what? Do you slap on a big cast for weeks?
That's a really key point, and actually the thinking has shifted a lot on this. The evidence now from systematic reviews like one by Hackle et al. Back in 2015 really supports short-term immobilization.
How short?
Like just 1 week, maybe even slightly less in some cases. Then the priority switches immediately to starting functional therapy, controlled range of motion exercises.
Just 1 week?
Yeah.
That sounds surprisingly quick for torn ligaments.
It does, doesn't it? But the rationale is that most simple dislocations, once reduced, are stable enough within the remaining soft tissue sleeve and the bony shape to allow early movement. And preventing stiffness is so critical in the elbow. Prolonged immobilization is really detrimental to the final outcome.
So the risk of stiffness outweighs the need for long immobilization for the ligaments to heal perfectly.
In most simple dislocations, yes, you get much better functional results if you get that motion back early.
And what are the typical results? Do people get back to normal?
The outcomes are generally pretty good. According to the notes, something like 75% of patients manage to return to their previous level of sports within about a year.
Okay, 75% is pretty decent. But what if it doesn't feel stable after reduction? Or maybe you take the slab off after that week and it still feels wobbly.
Right, that's the scenario where you need to think further. Persistent instability is the main trigger for more intervention. First step is usually getting an MRI. That gives you a detailed look at which ligaments are torn, how badly, and if other soft tissues are involved.
And based on the MRI.
Well, then the main options are either going for surgical repair of whatever's torn the LUCL, maybe the MCL capsule, or sometimes you might manage it non-operatively, but with a hinged elbow brace.
A hinged brace.
Yeah, one that provides external support against instability, but still allows flexion and extension within a controlled range.
How do you actually spot that instability, clinically or on X-ray? Is there a sign to look for?
Yes. There's a useful sign described by Coonrad and colleagues called the drop sign. You see it on the lateral X-ray.
A drop sign.
Yeah, basically it's an increased gap, an increased distance between the trochlea on the humerus and the olecranon process of the ulna. If that gap is there and stays there even after you've reduced it, or if you see it while the arm is still in the back slab, that's a pretty strong sign of significant instability.
So if you take the slab off at that 1 week checkup and you either feel it's really loose when you examine it or you see that drop sign on the X-ray.
That's a major warning. That patient likely needs either surgery to stabilize the ligaments or that hinged brace for a longer period. Because just starting standard therapy is probably not going to work. The joint isn't stable enough.
Is there like a definite rule for when surgery is absolutely required for a simple dislocation?
Not really a hard and fast consensus for all simple dislocations right off the bat. It's more about how things look after reduction and that initial week. Surgery comes into play mainly for that persistent symptomatic instability or maybe ongoing pain that isn't settling with non-op management.
Okay. And if you do go to surgery, what's the plan? What are you actually fixing?
You let the MRI guide you. Obviously, you're looking at the collateral ligaments, the LUCL and MCL. But don't forget the origins of the muscles around the elbow, the common extensor origin laterally and the common flexor origin medially. These are often pulled off too and need repair.
So multiple structures might be involved.
Often, yes. The usual sequence in surgery is to fix the LUCL first, typically using suture anchors to reattach it firmly back to the humerus. Then you reassess stability. If the medial side still feels unstable, you'll likely need a second, separate incision on the medial side to repair the MCL complex.
Right. And once you've done the repairs, how do you confirm in the OR that it's actually stable now?
You do a dynamic assessment under fluoroscopy, the X-ray machine. First, check it in full extension. Without you holding it, the joint should sit perfectly reduced, congruent. Then you carefully move it through the functional range of motion, usually about 30 degrees of flexion up to around 130 degrees.
Checking the whole arc.
Exactly. You're watching the screen and feeling the elbow, making sure there's no subluxation, no clunking, no feeling of instability anywhere in that important arc. If it's smooth and stable throughout, you're likely good to go.
Okay, that makes sense for simple dislocations.
So we've handled the simple ones. But what's really fascinating and frankly more challenging is when fractures get thrown into the mix, things get a lot more complicated then.
Right.
You start seeing these specific injury patterns, combinations of bone breaks and ligament tears that create unique stability problems. These are the elbow fracture dislocations.
Yeah, the ones with the scary names.
Okay.
I guess the main ones we hear about are the terrible triad. Then there's varus posteromedial rotatory instability, VPMRI, and also the transolecranon fracture dislocation. And maybe keeping Montagia variants in mind, too.
Exactly. Those are the key patterns to recognize. So just to define them quickly, the terrible triad, probably the most infamous, that's your posterolateral dislocation plus a radial head fracture plus a coronoid process fracture, typically just the tip of the coronoid.
Okay, 3 things. Dislocation, radial head, coronoid tip.
Right. Then VPMRI. This is different. It involves a specific type of coronoid fracture, the anteromedial facet, but usually without a radial head fracture. The key association here is an injury to the lateral collateral ligament complex. The elbow might be dislocated posteriorly or just subluxed, but it's that AM coronoid piece plus the LCL tear.
Got it. AM coronoid, LCL injury, no radial head usually.
Correct. Then the transolecranon type. This is usually an anterior dislocation where the forearm goes forward, associated with an olecranon fracture and often a fracture at the very base of the coronoid. The really distinguishing thing here is that the collateral ligaments, MCL and LCL, tend to be intact. And importantly, the joint between the radius and ulna near the elbow, the PRUJ, is usually stable.
Intact ligaments, stable PRUJ.
Okay, and the Montagia variant.
That's more of a differential. It involves an ulnar shaft fracture plus disruption of that PRUJ and often a radial head fracture or dislocation. So the key difference from transolecranon is the unstable PRUJ. That breakdown is super helpful. Okay, one of these complex injuries comes in. What are the immediate steps in the emergency department?
Priorities are always the same initially. Check the neurovascular status meticulously, pulses, sensation, motor function. You cannot miss a vascular injury or nerve deficit. Check carefully for any open wounds indicating an open fracture.
Right.
Then apply a well-padded back slab to immobilize and protect the limb. And then, this is absolutely crucial, get a CT scan. Plain x-rays just don't cut it for these complex injuries. You need the CT to really see the fracture details, especially the coronoid and the radial head, to plan your surgery.
The coronoid keeps coming up. It seems pretty important. How do we classify those fractures, and does it actually help plan treatment?
Yes, understanding the coronoid fracture is vital. There are 2 main classification systems mentioned. The O'Driscoll classification is often considered more helpful clinically because it's based on the anatomical location of the fracture, which tends to correlate with the overall injury pattern and ligament damage.
How does O'Driscoll divide them?
Into tip fractures, anteromedial rim or facet fractures, and basal fractures involving the whole base. Tip fractures are classic for the terrible triad. Anteromedial rim fractures are the defining feature of VPMRI, and basal fractures are typically seen with transolecranon fracture dislocations.
Okay, so the location tells you about the likely pattern. What's the other classification?
That's the Reagan-Mori classification. It's simpler, just based on the size of the fragment. Type 1 is just the tip. Type 2 is less than 50% of the coronoid height, and Type 3 is more than 50%. It gives you an idea of size, but maybe less about the mechanism than O'Driscoll.
So O'Driscoll for pattern, Reagan-Mori for size.
Got it.
And depending on the type, how might you fix these coronoid pieces?
Well, for small tip fractures, like in a terrible triad, sometimes a suture lasso technique, passing sutures through drill holes or around the fragment, can work. For the bigger anteromedial rim or basal types, you generally need more solid fixation. That might mean using a small buttress plate applied to the fragment, or maybe screws passed from back to front, dorsovolarly, to compress it.
Okay, let's really zoom in on the terrible triad now. Define it as dislocation, radial head fracture, coronoid tip fracture. You've got the CT, you've confirmed it. What do you need ready for the operating room?
Right. Definitive management is pretty much always surgery for a terrible triad. They're just too unstable otherwise. So preoperatively, you need your ducks in a row. Have the image intensifier, the C-arm, ready to go. Have options for the radial head, both plates and screws for fixation and implants for replacement.
Replacement options are key.
Absolutely. Headless compression screws for the coronoid if you plan to fix it. And, very importantly, have a hinged external fixator available, just in case you can't get it stable with internal fixation alone.
Be prepared for the worst-case stability scenario. Okay, intraoperatively, what's the typical surgical approach?
Usually, you start with a lateral approach. A common one is the trans-EDC approach, going between the extensor digitorum communis muscle and the anconeus. Sometimes you might need a a second medial incision as well.
And any specific tricks for that lateral approach?
Yes, a crucial one is to fully pronate the patient's forearm when you're exposing the deeper layers laterally. Turning the palm down like that rotates the posterior interosseous nerve, the PI, anteriorly and away from your dissection field, helping to protect it.
Pronate to protect the PI. Good tip.
Mm-hmm.
Okay, you're in. What bone do you usually tackle first?
Typically, you address the radial head first. You need to look at the fracture pattern. Is it fixable? Or is it shattered into too many pieces, say more than 3 fragments? If it's really comminuted, fixation is unlikely to work well. And putting in a radial head replacement is often the better choice for restoring stability and allowing early motion.
Replace if it's too smashed up. What if it is fixable?
Then you use small headless compression screws, or maybe a specialized radial head plate. The critical thing is where you put the hardware. It must be placed within the arc of safety.
Right, the safe arc. Remind me what that is again.
It's about a 90-degree zone on the articular surface of the radial head. If you imagine a line from Lister's tubercle on the back of the wrist up towards the radial styloid, the safe zone is generally posterior and lateral to that line. You put your screws or plate there so they don't rub against the ulna or the humerus when the forearm rotates.
Okay, keep the hardware out of the way of the joint articulation. Radial head is dealt with. Next
step is repairing the lateral ulnar collateral ligament complex. Usually this involves reattaching its origin back to the humerus using suture anchors drilled into the bone. Get that lateral side stabilized.
Radial head, LUCL,
Right.
then check stability.
Exactly. Once the radial head is stable, fixed or replaced, and the LUCL is repaired, you do that dynamic stability check under fluoro again. Move the elbow through the range. If it feels stable and looks congruent now, you might be okay. But if it's still unstable...
Then you have to suspect the medial side is also badly damaged.
Precisely. If it's still unstable after fixing the lateral structures, you need to address the medial side. That usually means making that second medial incision, maybe using the Hotchkiss over-the-top approach, and repairing the medial collateral ligament complex.
So, fix lateral, check if unstable, fix medial. What if it's still unstable even after fixing everything?
That's when you reach for the backup plan, the hinged external fixator. If you've repaired bone and both ligament complexes, and the elbow still wants to fall out of place, the X-Fix provides the necessary stability externally, while crucially still allowing controlled movement to start early.
Okay. And anything specific post-operatively for these big, terrible triad surgeries?
Yes, one very important thing is prophylaxis against heterotopic ossification, that's abnormal bone forming in the soft tissues, which can really stiffen the elbow. It's a known complication. So patients are often put on medication like indomethacin, usually 75 milligrams once a day, for about 6 weeks to try and prevent it.
HO prophylaxis, right? Now, back to that coronoid fracture in the terrible triad, often just a small type 1 tip.
Yeah.
Do you always have to fix that piece of bone surgically?
That's actually a point of debate, especially for those small type 1 tip fractures. There isn't complete agreement. Some surgeons feel that if you get good stability after addressing the radial head and the LUCL, you might not need to directly fix that tiny coronoid fragment. Sometimes just repairing the anterior capsule, which often tears along with the tip, might be enough.
So stability is the main goal, not necessarily fixing every single fragment.
Kind of. There's a study by Lucia and colleagues from 2014 mentioned in the notes. They looked at terrible triads with type 1 or even type 2 coronoid fractures and found good outcomes without coronoid fixation if the elbow is stable intraoperatively after the radial head and LUCL were dealt with. So it emphasizes assessing stability dynamically in the OR.
Just a reminder for everyone listening, this deep dive is based on the Ortho Made Simple notes, which you can find over at mokyingren.sg.
Okay, let's pivot now to a different, quite distinct pattern, those anteromedial facet coronoid fractures. These are the hallmark of varus posteromedial rotatory instability, or VPMRI.
Right, VPMRI. So that's specifically the AMF coronoid piece plus what else defines it? It's usually not the radial head, you said.
That's correct. VTMRI is defined by that AMF coronoid fracture, and crucially, it's associated with injury to the lateral collateral ligament complex. Unlike the terrible triad, you typically don't see an MCL injury or a significant radial head fracture with VPMRI.
AMF plus LCL. Okay. Why is recognizing this pattern so important?
Because the risk is significant if it's missed or undertreated. If you have that AMF fracture combined with LCL insufficiency and you don't address both, the elbow will remain unstable in varus and posteromedial rotation. This leads to abnormal joint loading and a very, very high risk of developing severe post-traumatic arthritis relatively quickly. You really have to identify and treat this combination.
High risk of arthritis. Got it. Are there specific classifications for just these AMF fractures?
Yes, O'Driscoll further subclassified these AMF fractures, which is helpful for treatment planning. Subtype 1 is just the AMF fragment itself. Subtype 2 involves the AMF and extends to include part of the coronoid rim. Subtype 3 is the largest, including the AMF, the rim, and the sublime tubercle, which is where the MCL actually attaches.
So the subtypes indicate increasing size and involvement. Can you ever get away with treating VPMRI non-operatively?
It's very uncommon. The indications are really narrow. Based on a systematic review by Fabian Landsrath mentioned in the notes, conservative management should probably only be considered for truly undisplaced type 1 and maybe type 2 AMF fractures where the joint remains perfectly congruent on imaging. Most VPMRI injuries need surgery because of the inherent instability from both the bone and ligament damage.
Okay, so usually surgery. How does that O'Driscoll subclassification help decide what surgery to do?
It guides what needs fixing. For a subtype 1, where the AMF fragment is small and the main instability driver might be the associated LCL tear, surgery might just involve repairing the LUCL, often with suture anchors.
Just fix the LCL for type 1.
Potentially, if the coronoid fragment is small and stable, yes. But for subtype 2 and 3, with larger, more significant AMF fragments, you absolutely need to achieve stable fixation of that coronoid piece, usually with a buttress plate. And you also still need to repair the LCL.
So bigger fragment means fix the bone and the ligament.
Exactly. This often means using dual incisions, one medial for the coronoid and one lateral for the LCL. And after fixing those, you still need to carefully check the MCL stability and consider repairing or reconstructing it if it's also found to be injured or avulsed, especially in type 3 fractures involving the sublime tubercle.
What are the typical surgical approaches then, particularly for getting to that AMF fragment?
It depends a bit on the subtype. For an isolated type 1 AMF, where maybe you're just fixing the LCL and checking the MCL, you might use separate lateral and medial approaches. However, for the more common scenario needing fixation of a type 2 or 3 AMF fragment, the usual sequence is start medially. Use an approach like the Hotchkiss over the top to get direct access to the anteromedial coronoid. Fix that fragment securely first.
Fix the bone first medially.
Right. Get that bony buttress reestablished. Then, make your separate lateral approach and repair the LUCL. Finally, you might need to go back to the medial incision to reassess the MCL and repair it if necessary.
Medial bone, lateral ligament, medial ligament, check fix. That makes sense. Okay, let's cover the last main pattern. The transolecrain fracture dislocation. What's the key feature here?
This one's the least common of the complex fracture dislocations we've discussed. The defining characteristic is that the collateral ligaments, both MCL and LCL, usually remain intact. The injury happens when the elbow dislocates anteriorly, but it does so by fracturing through the olecranon process. So the ulnohumeral joint is completely disrupted through that fracture line.
So the ligaments hold, but the bone breaks to allow the dislocation. You mentioned it could be confused with the Monteggi variant. How do you tell them apart?
The key differentiator is the proximal radial joint, the PRUJ. In a transolecranon injury, because the annular ligament around the radial head is typically intact, the PRUJ remains stable. In a Monteggia lesion, by definition, you have disruption of the PRUJ along with the ulnar fracture. So checking PRUJ stability is crucial.
Stable PRUJ means transolecranon. Unstable PRUJ points towards Monteggia.
Okay. Since the ligaments are usually intact, are the long-term outcomes generally better for these compared to, say, a terrible triad?
Yes, generally speaking, the outcomes tend to be better. You don't have the same degree of complex ligamentous instability to manage. The main challenge is getting a perfect anatomical reduction and stable fixation of the olecranon and any associated coronoid fracture to restore the joint's surface.
How are these typically managed? Surgery. Yes, open reduction and internal fixation, or RF, is definitely the preferred treatment. While you could theoretically consider non-op for a truly undisplaced fracture, which would be unusual in a dislocation scenario, RF is generally needed to restore the articular congruity, prevent arthritis later on, and allow for early motion, which is still important.
What's the surgical approach and fixation strategy?
You usually use a direct posterior approach, sometimes called a posterior global approach. This gives good access to the olecranon and the back of the humerus. You have to create a medial flap carefully and identify and protect the ulnar nerve. It's very close by and vulnerable here.
Protect the ulnar nerve. Then what do you fix first?
Working from that posterior approach, you generally fix things sequentially. If there's an associated coronoid fracture, especially a basal one, you might address that first, perhaps with headless screws, anchors, or sutures passed through drill holes. Then you restore the length and alignment of the ulna and fix the main olecranon fracture, typically using an olecranon-specific plate and screws. Finally, if the radial head is also fractured, you can usually access it through a lateral window or flap from your posterior incision to either fix it or replace it if necessary.
Okay, so coronoid, then ulnar olecranon, then radial head if needed, and post-op, similar precautions.
Yes, typically a back slab for initial immobilization. And again, given the significant trauma and surgery, HO prophylaxis with indomethacin, that 75 milligram daily dose for about 6 weeks, is definitely something to consider strongly.
Right, wow. We have certainly covered a lot of ground today. We started with the basics of simple elbow dislocations, that circle of Horry progression.
The mechanism, the reduction.
Safely reduction, the importance of early motion, the drop sign. And then we really dove into the complex fracture dislocations, the terrible triad, VPMRI, transolecranon. We've tried to dissect what defines each pattern, the classifications involved, and the key steps in surgical management for each.
And if we tie this back to why you, the listener, are tuning in maybe for exams, maybe for improving your clinical practice, really getting to grips with these specific patterns is just crucial. It's not only about fixing the broken bones you see on the x-ray.
No, it's more than that.
It's about understanding the instability mechanism behind each pattern. Is it mainly ligaments? Is it bone loss? Is it a combination? Because that understanding is what truly guides your whole treatment strategy. It tells you what needs to be fixed to restore stability, allow that essential early motion, and hopefully give the patient the best chance of avoiding long-term problems like stiffness or arthritis.
That's a great summary.
Yeah.
And just to remind everyone one last time, this deep dive was based on the Ortho Made Simple notes, which are available on the website mokyingren.sg.
And perhaps this leaves you with a final thought to mull over. We've talked about different approaches, especially for things like instability and coronoid fractures. When you're faced with one of these really challenging elbow fracture dislocations in your own practice, how will you navigate that critical balance? The balance between needing rigid fixation for the fractures to heal versus the absolute imperative to get the elbow moving early to prevent that devastating stiffness. Where will you draw the line in your surgical plan?